Hello, this is Dr. Pankaj Jindal. I'm a hand surgeon in the city of Pune in the state of Maharashtra in India. Today we will talk about fracture of the metacarpal 5 neck, including the boxer's fracture. It's a fracture of the neck of the fifth metacarpal. There is a misnomer. It is called a boxer's fracture. It is never seen in professional boxers. Usually, the mechanism of injury is a clenched fist striking a solid object and is usually seen in a brawler following hitting a hard object like a wall. The fracture of the fifth metacarpal neck fracture, there is a loss of prominence of the fifth metacarpal head if you clench the fist. As you see in another picture, the prominence of the fifth metacarpal is lost because of the fracture pattern. At times, there might be, in addition to flexion of the fracture fragment, there might also be rotation of the fragment. The solution of this problem lies in an anatomical fact. And what is this anatomical fact? In extension, the small finger is significantly shorter than the ring finger, whereas in flexion, additional flexion of the carpometacarpal joint 5 occurs, and this leads to a small finger appearing almost equal to the ring finger. And therefore, in extension, the small finger is shorter. In flexion, the small finger comes to lie almost equal to the adjacent ring finger. And this is because of the 30-degree extra motion of the fourth and fifth carpometacarpal joint. And this fact is utilized to compensate for 30 to 70 degree of flexion of the fracture of the fifth metacarpal neck. So the anatomical fact is there is a relatively high degree of motion of the fifth CMC joint as against the second, third and fourth. The fracture of the fifth metacarpal can tolerate a marked angulation in the AP plane. So other treatment, you can treat it conservatively and you can treat it surgically. How do you treat it conservatively? Often they don't usually require a manipulation. Flex fracture is relocated if at all required. It is derotated if it is rotated, if at all. Usually it will not be, but if at all, which will be seen by scissoring, you have to derotate the fragment. Historically, there was a maneuver which was called a jazz maneuver. And what this requires is, will be talked to you, but this is almost abandoned. And what this involved was under anesthesia, a counter force is given to the metacarpal shaft and a force is applied to the flexed proximal phalanx, and a dorsal pull will render the fracture stable. But there were a lot of problems with this jazz maneuver. The problems were related to the stiffness, problems were related to skin complications. There would be pressure sore on the flexed PIP joint, flexion contracture of the PIP joint, and the recurrence of deformity, and therefore this has no longer being used. In one of the articles which came in 2008 in Journal of Hand Surgery, they compared two methods of immobilizing a fracture of the fifth metacarpal. A plaster applied with extended MP joint, another outrigger splint. And surprisingly, there was no difference in the two methods of immobilization. Because of the fact, on the volar side, there is a significant amount of comminution, and therefore, once the immobilization is removed, there is a tendency for the fracture to fall back in its original malalignment. Because almost all of them, if treated conservatively, lead to a total collapse. So, do fracture of the fifth metacarpal at all require an intervention? Several authors have reported functional results can be achieved with little or no correction, and therefore you need not do anything if the flexion of the fragment as seen on the lateral view is 40 to 70 degrees. Let's take one clinical example where the patient was treated conservatively. This patient had a fracture of the fifth metacarpal and was treated conservatively, and you'll appreciate the amount of flexion he has of the fifth metacarpal. Yes, there is some amount of loss of prominence of the fifth metacarpal. So discuss with the patient that if you operate, that's one possibility, but this can as well be treated conservatively. The only thing is he may not see the prominence of the fifth metacarpal. Otherwise, he can have a full range of motion if treated conservatively. So what are the indications of surgery? if there is an angulation which is more than 70 degrees, if it is rotated as seen by scissoring, if there is an in association a fracture of the small finger, if it is an open fracture or there is a deformity, these are the indications which require surgery. There are many methods of treating it operatively. Most of the methods are treated operatively, if at all, are closed methods by percutaneous fixation. Of course, open reduction is also possible. Plating is also possible. Traction, longitudinal and transverse KYs can also be used when treating it, if at all, operatively. Very important, treat the patient and not the X-ray. Now coming to the operative management, you can reduce it and put longitudinal KYs, but remember this will impale the extensor tendon and cause restriction of movement of the MP joint. There are various methods of operative management: parallel KYs, oblique KYs which are converging, intermetacarpal KYs, or plating. When you use this kind of internal fixation using KYs, you are likely to impale the extensor tendon, will restrict the MP joint flexion. When you use KYs from the metacarpal 5 into metacarpal 4, you impale the interosseous muscles, again restricting movements of the MP and the PIP joint. You can use plate, but the possibility of adhesion to the extensor tendon is high. In addition, of course, a long scar on the open exposed dorsal aspect of the hand. So plating is a possibility, but it brings its own problems. So in my hands, I would rather treat this with KY rather than plating. The one method that has become extremely popular and is the method of choice for fixation in our hand is Foucher's technique or the bouquet technique, where the wires are inserted from the base of the fifth metacarpal. Very important when you are putting these KYs is to avoid any damage to this sensory branch of the ulnar nerve, because this nerve can get damaged and give rise to a very severe painful neuroma here. So how do you do this? Under anesthesia and tourniquet, 1.5 centimeter incision is given on the base, nerves and tendons are retracted, base of the metacarpal 5 is identified, and an entry hole is made. Entry hole is made using a bone awl, an entry hole on the ulnar side of the fifth metacarpal. The K wire is used, 1.2 millimeters, slightly bent on the distal part, and this bent K wire is inserted inside. This is a schematic representation. After making a hole, the K wire is inserted inside metacarpal base. It can be a free hand if you bend it proximally, or it can be mounted on a T handle. So once you reduce it, the wires are inserted using a C-arm, the factory is relocated, and more than one wire, 2 to 3 wires can be inserted and start the range of motion as soon as the pain allows. Entry hole is extremely small and you can almost always get a good range of motion if this injury of the fifth metacarpal. The important thing is this is a close reduction and does not require opening the fracture site. And this is the patient who had a full range of motion as early as 7 weeks post surgery. Do you require an incision to enter the KY? It's an absolute must. Making a blind entry can damage the sensory branch of the ulnar nerve, and therefore making a small incision is helpful. It may look dark to start with, but with passage of time, this scar also disappears in all the patients. There are other methods of fixation which have been described. You can pass in the wire from the dorsum, from the distal to proximal, from proximal to distal, intermetacarpal or cross K wires, as we have discussed. All methods have their advantages and disadvantages. But the one that we choose is the wire passed from the base with an open exposure of the base of the fifth metacarpal. I thank you very much for patient listening.